From Microbe TV, this is Infectious Disease Puscast episode 90, recorded on Monday, September 29th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. I actually, for our banter section today, I got excited because I saw it was World Rabies Day, and I was like, oh, we'll talk about it. But it actually was yesterday. And
That's okay. That's okay.
So I think I can still bring it up because it was the 28th, which was Sunday. And I was thinking, I was like, oh, usually we have rabies something or other on the show every once in a while. But I don't think we've had anything too recently.
It is kind of amazing how often rabies ends up in the news. I think it's a part of it is just the fascination I think we have with rabies and popular culture and, the rabid dogs and got rabies, I think, in the local this is a great one. You're going to love this, Sara. So we have rabies in the local raccoons here, right? And there was a few weeks back, some woman's like in her backyard in a lawn chair, and next thing you know, she gets bit by a rabid raccoon right in the middle of the day. So everyone's on high alert. So one of my partners, Dr. Lee, shows us this photo. She's like, yeah, I saw this in my backyard. And I'm like, oh, that's such a cute fox. She's like, yeah, that's what the mayor said. I thought it was a rabid raccoon. I'm like, Anuja, you know the difference between a fox and a raccoon? Apparently that is a city girl.
I'd like to think I could tell the difference between those two, but who knows?
So, yes, it was not a rabid raccoon, but it was actually just a very cute fox.
Well, either way, that seems like it would spoil the afternoon to be bitten by a fox or raccoon, but I guess the raccoon would obviously be worse.
Yes.
Oh, all right. Well, welcome everyone to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? We will open up with our viral section, of course. Remember to listen to This Week in Virology and the clinical updates. Anything you want to point out for folks, Daniel?
Well, we've got a lot of stuff going on there, sort of really become important for us to discuss the science, the actual science, the truth, not just all that misinformation that other folks are trying to peddle on us. So keep listening. We'll keep sharing it all.
Well, the first one I have is pretty quick, but I think a question that comes up not infrequently, especially on the inpatient service. This was an OFID evaluating the efficacy of crushed bictegravir, emtricitabine, tenofovir, alafenamide administered via tube. This was a retrospective study. They found that 89%, so 17 of the 19 patients included, who received Biktarvy crushed or dissolved and through an enteral tube were virally suppressed at follow-up, basically suggesting to us that crushed and dissolved solution can help achieve or maintain viral suppression in patients. Before that, we've mostly had case reports, but this aligns with what is mostly out there in the literature. So they included individuals who received the antivirals through enteral tube. Most of them had a median of 19 days of the antiviral that way, and 3/4 of those were switched in the setting of intubation. So,
yeah, that's good to know. All right, excellent. Next patient we have that needs their Biktarvy through the feeding tube. We can crush it and go ahead. All right. This is actually pretty appropriate for this section and the times that we are living in. The research letter tracking county-level measles cases in the U.S. published in JAMA. They start off with a really nice introduction, just sort of wake everyone up to the fear on the horizon. So prior to the introduction of the measles vaccine, more than 90% of U.S. residents were infected with the measles virus before the age of 15, with 3 to 4 million annual cases of measles, resulting in approximately 48,000 hospitalizations. So I mean, just sort of pointing out, like, measles is not like, what is they try to portray as, oh, the Brady Bunch, a bunch of people missing school with a little bit of a rash. 48, and this is when there were less people in the United States, right? So 48,000 hospitalizations, tens of thousands of hospitalizations, millions of cases. And then as we've sort of tried to discuss repeatedly, it's not just the people that ended up in the hospital. It's not just the people that died during the acute period. There is a significant increase in childhood mortality for the following several years afterwards. Sarah, I don't know if you listened to Debunk the Funk with Dan. I think it's Dan Wilson does that. Really like a nice recent one, Show Me the Paper, where they actually go through the papers showing that as measles vaccine was introduced throughout the world, you saw this really nice drop in childhood mortality, not just acutely, but in the 2 to 3 years because of that horrible impact of measles on immune memory. Well, building on their experience with timely infectious disease surveillance through the Johns Hopkins University COVID-19 dashboard. This group developed an infrastructure to track confirmed measles cases as they are publicly reported across all affected counties in the U.S. For the most affected states, they present state-level cumulative and weekly incidence curve, national-level distributions of vaccination status and age groups for all confirmed cases is presented. All dashboard components and underlying data are directly downloadable. So really, as we start to have issues, like, will we be able to trust the data that we're getting from the CDC now that we have lawyers sort of deciding, who passes the anti-science litmus test to be there? We're going to actually have another alternative way of tracking what's going on with measles. So nice article here describing that. I'll also leave in links to the Johns Hopkins U.S. Measles Tracker. You can follow the link. I've been following it, and so far the CDC and the Hopkins have been pretty much on par. But here we have another source of information.
Cool. And this next one I have is from MMWR, Pediatric Influenza Associated Encephalopathy and Acute Necrotizing Encephalopathy, United States 2024 to 2025 influenza season. This report shares how 109 U.S. pediatric influenza-associated encephalopathy cases were identified during the prior flu season. These were children with a median age of about 5 years old. 55% of the affected children were previously healthy, and just for another pearl, it looked like about 89% had flu A. 37 of those cases were subcategorized with acute necrotizing encephalopathy, which is the more severe form characterized by rapid neurologic decline and quite a poor prognosis. And so 74% of the influenza-associated encephalopathy patients were admitted to the ICU. 19% died. But sort of zooming in on that, 41% of the patients with the necrotizing encephalopathy died. And so only 16% of vaccine-eligible influenza-associated encephalopathy patients had received the flu vaccine. So just a public service announcement. I know that most of the people who listen to Febrile probably are the ones giving these announcements, but why not have it in another forum? Influenza vaccine reduces flu-associated hospitalizations and ED visits and is recommended for all children 6 months and older to prevent flu and COVID complications. And that would include neurologic disease like these encephalopathy or necrotizing encephalopathy cases.
Yeah, Sarah, I was recently presenting to a New Hampshire pediatric group, and they had a young child develop this acute influenza encephalopathy. And it's really, it's sort of reminded me of kind of the dynamic of COVID, where you start off with the viral replication. And this is a slightly delayed inflammatory response. And not only, are we having, about 10%, if you look at the number of the pediatric deaths being due to this, if you looked at this case series, the majority of these kids, even if they survived, I think 68% would have ongoing neurological and other issues. So really just a horrible, and again, the majority of these we do think would be vaccine preventable. And so we've got to do something where, unfortunately, the anti-science movement is undermining trust in childhood flu vaccines. I mean, almost, 280 children died last winter from influenza, 90% of those unvaccinated. Majority of those not getting antiviral medicines. So really, we need to go back to the days when the majority of children got the flu vaccine, when we had maybe half of the number of deaths that we're currently seeing. All right, MMWR, we have clinical recommendation for the use of injectable lenacapavir as HIV pre-exposure prophylaxis, United States 2025. And really, the abstract says it all, but don't worry, my commentary is added as we run through this. So in 2023, approximately 39,000 persons received a diagnosis of HIV in the United States. So comment added. I just want to point out, this is an ongoing issue. We have over 1 million people here in the United States that are HIV positive, and we continue to see another 40,000 or so new infections every single year. Like, this is not in the rear view mirror. Now, HIV pre-exposure prophylaxis, or PrEP, is highly effective in preventing HIV infection, but acceptance of, adherence to, and persistence taking the available oral and injectable PrEP regimens have been suboptimal. CDC PrEP guidelines published in 2021 included 2 oral tenofovir-based options and cabotegravir. This was the only injectable PrEP regimen approved by the FDA at that time. Now, just to point out what is cabotegravir, get everyone up to speed. So cabotegravir, or Apretude, is injected monthly on month 1 and then month 2, and then every 2 months going forward, right? So that was the injectable option before. Now, moving forward, June 2025, the FDA improved injectable lenacapavir. This is every 6 months, twice a year. Instead of 6 times a year, approved as HIV PrEP based on the results of 2 really impressive randomized control trials, Purpose 1, Purpose 2. The CDC PrEP guideline work group assessed evidence for the efficacy and safety of Len PrEP using the grading of recommendations, assessment, development, and evaluation. That's the GRADE approach, GRADE approach. The 2 trials reported Len efficacy at reducing HIV infection, 100% among females, 96% among a primarily male trial population, compared with the estimated background HIV incidence over 52 weeks. No significant safety concerns. Most common adverse reactions were mild, moderate, really just injection site reactions. Based on a high certainty of evidence for the efficacy and safety of Len as assessed by the GRADE analysis, subcutaneous injection of Len every 6 months strongly recommended as a PrEP option in persons weighing 77 pounds or more who would benefit from PrEP. They point out that this really has the potential to improve PrEP adherence, but cost issues. The list price in the United States for PrEP, $28,218 per year. Using it for treatment, $42,250. Now, interesting enough, you can make this, and this can actually be distributed in low and middle income countries for $25 to $46 per year. So really a huge markup here compared to the actual cost of this medication.
All right. Oh, I'm opening both of our first
I
2
moved
sections.
your stuff around. I did that
I love
too,
it.
Sara.
All right, let's jump into bacterial. Be sure to listen to This Week in Microbiology. So I have 2 papers I pulled today. The first one's from Antimicrobial Stewardship and Healthcare Epidemiology. It is entitled Use of Primary Oral Vancomycin Prophylaxis to Stem an Outbreak of Clostridioides difficile Infection in Intensive Care Patients. Authors here share the use of, as the title says, primary oral vanc prophylaxis at the 125 milligrams once daily dosing during a sustained outbreak of hospital onset C. diff infection in ICUs in a Brooklyn hospital. They specifically targeted patients who were 60 and older, hospitalized for at least 7 days or had been recently hospitalized in the past month, and who were receiving high-risk systemic antibiotics. So they qualified if they had piptazo, cephalosporins, fluoroquinolones, and or clindamycin. They do actually note that they use the BID dosing for the, quote, severely immunocompromised patients. And then generally the prophylaxis was continued for up to 5 days post-completion of that systemic antibiotic therapy that they were on. So they found in their study, high-risk elderly patients had a significant decrease in the hospital onset C. diff infections in ICUs. So over about 5 months, the baseline went from about 6 cases to 19 cases per 10,000 patient days. So that was the jump in the outbreaks that they were seeing. They started the oral vanc prophylaxis, and then that adjusted back down to 5.7 cases per 10,000 patient days. They did find a non-significant but noted increase in VRE in the ICUs during the period of this primary oral vanc prophylaxis intervention, which led to the stop of this intervention at about 5.5 months. There are some other confounders. It's retrospective cohort. There was a decreased use of cefepime during the intervention period, but ultimately those patients were instead getting levofloxacin. So really, I thought it was pretty interesting. We have a bit more data thinking about secondary prophylaxis for C. diff. I think primary prophylaxis is still, I would say it's still controversial. This was a unique setting, obviously, with an outbreak, but I thought it was a pretty cool paper, so I thought I would share it.
Yes. I mean, it's an interesting study. I would have loved like a placebo, like some sort of a better control group, because like basically our baseline was 6, and then we had this outbreak, and now it's back to 6. Would it have gone back to 6 anyway? Mm-hmm. It would be great not to have C. diff and to have some really clear data. But yeah, it's also the interesting, like, what is the dose? What is the prophylactic dose? Is it once a day? I mean, I understand they did it twice a day and the seriously ill, but why?
Yeah, exactly. All right. And then the other paper that I pulled was from OFID, Clinical Features and Treatment Strategies of Q Fever Spinal Infections, a pooled analysis of 39 cases and a narrative review of the literature. So this paper summarized clinical characteristics of Q fever spinal infection. They tried to look at some kind of what they consider distinct clinical subtypes that we'll touch on. But I think one of the things they really emphasize is how in endemic areas, spinal infection that may be presumed as TB, but is not responding, may ultimately be reclassified as a different organism. And so they had some cases here that metagenomic sequencing helped find the diagnosis ultimately. So their case, for example, was a 57-year-old male in China, admitted with this sort of acute on chronic lower back pain, had later or subsequently had fever, was IGRA positive. It was kind of presumed that he had spinal TB, but he wasn't responding. I guess in retrospect, they do learn that he was collecting sheep manure from a nearby farm, but basically down the road gets a vertebral biopsy that identifies Coxiella. And so why not review Q fever? Because we don't see it that often. So Q fever is caused by Coxiella burnetii. It's globally distributed zoonotic disease. We think of the primary reservoirs of sheep and goats and cattle, and human infections usually occur through inhalation of contaminated aerosols. So that classic sheep birthing vignette in ID board review, but ingestion of infected animal products or direct mucosal or skin contact can also transmit infection. And so, they reviewed about 40 additional cases from the literature looking specifically at this Q fever causing spinal infection, kind of building off some prior reviews. And they outlined all of it in their figure 1, kind of pointing out what they felt like were important clinical implications that they found. One of the things that I thought was interesting is they kind of focused on this isolated spinal infection versus aneurysm associated sort of combo with spinal infection. And they obviously have a couple different cases that are reported in here, but this question of whether patients who have Q fever spinal infection coexisting with aortic aneurysm infection, and whether that is related to hematogenous dissemination versus local extension that ultimately involves the aorta. I have not seen Q fever. I have not, as you may have guessed, had to encounter it, but that was an interesting learning point for me. And I was going to say, we have a febrile episode on Q fever that I need to edit and release. And so this is making me accountable by announcing that I need to do it.
Doesn't it get you excited though, Sarah? You feel like one day, like there's all the list of diseases that you haven't seen yet, and one day you will see. And
yeah. They don't give any specific guidance. I think the question on how you treat Q fever, they don't really necessarily address that. They kind of explain what their patient received. But I think that's another thing that is also challenging, of course, about treatment of Q fever. But we'll have to save that for a future episode. All right. And then I will take us into our fungal section. We don't really have anything to announce for that. We're kind of in between Last of Us seasons. I pulled one paper from JID because I read the title and I kind of knew who the author was just from the title. The pain is in the brain with the sugar-coated killer. And of course, when I checked the author line, it did have John Perfect. So this was an invited translational science update. So Doctors Messina and Perfect detailed some virulence factors and their pathways related to Cryptococcus neoformans and Gattii. They shared these 3 mechanisms of entry, presence, and elimination. So entry involves mechanisms of yeast dissemination from the lung and crossing the blood-brain barrier. Presence relating to fungal burden of these infections in the CNS and how yeast can become a target for the host immune system, and then elimination marked by fungal clearance, but also when we run into challenges with aberrant immune responses like iris and post-infectious inflammatory syndrome. And they, I should have said this is kind of focusing on meningitis, that example I just read off. One of the examples of the yeast entry mechanisms is the Trojan horse, where there is intracellular passage through immune effector cells. And I didn't know this. Apparently, there's studies that show that mice inoculated with macrophages containing yeast forms have significantly higher brain fungal burden at 24 hours post-infection than mice that are infected with free yeast. And of course, as the title alludes to, they obviously talk about the polysaccharide capsule, virulence factor. And so I just grabbed the final sentence from their future directions conclusion paragraph. Cryptococcal meningitis, as the pain in the brain, requires 3 missions: early diagnosis, efficient killing of the yeast, and careful management of host responses. So a really nice review if people want to get caught up on what is out there in the literature.
Okay. All right. If you were thinking I didn't bring any papers, here we go. Heavy on the parasitic section. So be sure to listen to This Week in Parasitism. And a little concerning was the MMWR report, Chagas disease, an endemic disease in the United States. So just a little background for folks. So Chagas disease, or American trypanosomiasis, is caused by the parasitic protozoan Trypanosoma cruzi, which is transmitted through congenital, oral, and vector-borne routes. So vector-borne infections result from contact with the feces of infected tradomine insects, kissing bugs, and that's what we commonly call them here in the United States. The blood-sucking insects occur naturally in the southern half of the country and have been identified in 32 states. Of all 11 tradomine species, the Reduvidae bugs found in the U.S., 9 have been found to be naturally infected with T. cruzi. Of these, there's 4 species that are commonly found in human dwellings. So this raised this concern for increased opportunity. Numerous investigations of these bugs in the United States have revealed that they harbor the T. cruzi parasites. And are you ready for this? Infection prevalence ranges from 30 to greater than 50%. Now, Tridotoma sanguisuga and T. protracta kissing bugs have the largest overall distribution in the U.S., but the T. Kersteri kissing bugs appear to be the most common species in domestic settings in Texas and are likely responsible for transmission, resulting in locally acquired T. cruzi infection in dogs and humans. So autochthonous, right? That's when you get it right here without traveling anywhere else. So autochthonous human T. cruzi infections have been identified in 8 states. I'm going to throw in the already. So we've already identified people just staying here in these 8 states and getting Chagas disease. This is in California, Arizona, Texas, Tennessee, Louisiana, Missouri, Mississippi, Arkansas. They did this systematic literature review. They found 29 confirmed, 47 suspected cases of locally acquired Chagas disease during the 2000 to 2018 period. And they found some shared risk factors of rural residents, history of hunting or camping, agriculture or outdoor work. And they point out, I just think we have to agree, that those numbers are likely greatly underrepresenting underlying human infections. And so here's a couple things I want to say. So tridamine species from the southwestern United States have been shown to have a longer post-feeding defecation behavior than more efficient tridamine vectors in Latin America. And that behavior has been suggested to reduce the risk for contact between infectious T. cruzi and the host. And I am guilty of this narrative. As they point out, that narrative has contributed to the perception that the kissing bug species in the United States are not capable of this, I love this word, stercorarian transmission, right? That's like basically feces transmission, because there's this whole idea, right? So the kissing bug basically bites, leaves a wound, or maybe it's up near the eye, and then while feeding, some of these other types of bugs down like south of us will immediately be defecating as they're feeding. So we have this narrative, because it takes a little while, maybe they move on before they defecate, so maybe that the parasites in the feces don't end up in the wound or in the eyeball. But that whole narrative, unfortunately, has sort of suggested to people that, we don't have to worry so much. So basically saying, stop telling that narrative, because as I pointed out, we've got 8 states here where people are getting it in the U.S. with these kissing bugs. So we do have highly competent rejuvid bugs for this transmission here. T. cruzi and the ecological conditions that sustain its transmission cycles are naturally occurring throughout the southern half of the United States. Infection has been consistently demonstrated in wildlife reservoirs, companion animals, zoo and exotic mammals, and humans. And at least 4 of the kissing bug species frequently encountered in the homes found to be harboring T. cruzi parasites. So basically, Chagas disease is endemic in the United States. All right. This is one where I think we'll get maybe some listeners if we put this in the title. You ready for this, Sarah? The article, Fixed Dose Ivermectin for Mass Drug Administration. Is it time to leave the dose poll behind? Insights from an individual participant data meta-analysis published in PLOS NTDs. Right, everyone loves ivermectin. It's widely used in mass drug administration programs for the control of neglected tropical diseases. Recently was that article about using it really as kind of an insecticide, right, for malaria, mass drug administration. Well, those of you listeners that have been in some of these areas may be familiar with the fact that current regimens rely on weight or height-based dosing, which lead to some operational challenges. I'm going to say some operational challenges. So this study looks at an age-based fixed-dose regimen for ivermectin, so you don't have to wander around with those poles and stand people up and measure everybody. This is an individual participant data meta-analysis, including, I love this, anthropometric data from over 700,000 individuals across 53 neglected tropical disease endemic countries. So fixed dose regimens were based on weight distribution by age. The proportion of individuals achieving the target dose was assessed and compared to traditional dosing regimens. And as I point out, anthropometric data is just a fancy way of saying they measured the height and weight. And so you've got these fixed doses of the 3 milligrams for the preschool children, 9 milligrams for the school-age children, 18 milligrams for women of reproductive age. Just want to point out there, we kind of shy away from maybe the first trimester because of some animal data. But anyway, when they compared this, they basically found that underdosed individuals were fewer with the fixed dose compared to the weight and the height-based regimens. Although doses above the target range increased slightly, most remained within this 600 microgram per kilogram. So basically, an age-based fixed-dose regimen for ivermectin could improve treatment coverage and simplify the MDA activities. And I pasted in this little picture from path.org. I don't know if you've ever seen these polls, Sarah, but they're really, they're cute, right? So you've got these, the bottom is red and then yellow and then kind of this turquoise green and then fuchsia at the top. And I kind of like them. They're fun. And you walk around with your stick and you stand, and based upon this is how many of the ivermectin pills you get. And
oh, that makes sense. Yeah, we have, when you do the, like the pediatric, what's the right word? Like CPR type training. We do have little cards sometimes that do dosing, and it makes sense. You could just put on a stick with pulse and the stick looks nicer.
Yeah, you walk around with the multicolored stick and that they know who you are. Oh, the ivermectin person.
Yeah, it makes sense. And then I also pulled something that I threw into our parasitic section here from AJTMH. Cultural and clinical insights from an outbreak of eosinophilic meningitis caused by the rat lungworm, Angiostrongylus cantonensis in South Brazil. So as a refresher, Angiostrongylus is a neurotropic parasite that causes eosinophilic meningitis. It's classically transmitted through ingestion of contaminated produce or undercooked snails or slugs. And this paper reported 2 cases of eosinophilic meningitis in previously healthy adult men who developed a kind of subacute neuro syndrome. They had progressive lower limb weakness and severe neuropathic pain. They both actually had some alternative diagnoses early on, getting called UTI, getting called gout. They ultimately were found to have a shared exposure event, which was ingestion of raw slugs during a religious ritual, which has not been well described as a transmission route before. Both the patients were treated with albendazole, ivermectin, and steroids for 2 weeks, and fortunately both recovered with normal CSF parameters 2 weeks out. I just really loved how this was a combination of a review of the topic, of course, but also a reminder about culturally sensitive history taking and communication. It sounds like there was some reluctance from the patients to disclose the exposure, which may have stemmed from stigma, religious privacy, lack of awareness of health risk associated with infections related to snails or slugs. And I learned a little bit. So syncretic spiritual traditions in Brazil can incorporate African, indigenous, and Christian influences, and certain non-Christian religions with African origins are highly stigmatized and often can lead to violence and marginalization of practitioners. And so another thing that I learned, kind of unrelated, is that this parasite was first identified in Brazil and only in 2013, which seems wild because that's very recent. And I just wanted to highlight they have a really nice acknowledgement where they say, "We are grateful to the team behind the podcast This Week in Parasitism, with special acknowledgement of the late Dr. Dixon de Pommier for his invaluable contributions to parasitology and his lasting impact on education in the field. The podcast insights and discussions were a meaningful source of inspiration for this work." So,
oh wow,
many, many things to love. Really nice. I wasn't excited. I didn't even know that was going to be in there. So gave me an extra reason to throw it in today.
Wow. All right. Nice. Well, thank you guys. All right. The article, Human Monoclonal Antibody MAM01, MAM01 for protection against malaria in adults in the USA, a first-in-human phase 1 dose escalation, double-blind, placebo-controlled adaptive trial published in the Lancet Infectious Disease. So phase 1, right? So this is supposed to be like a dose escalation. You're supposed to be too focused on the efficacy, sort of more of like what is the right dose and how's it tolerated. So phase 1, dose escalation, double-blind, placebo-controlled adaptive trial done at the Center for Vaccine Development and Global Health, University of Maryland, Baltimore. Adults aged 18 to 50 years with no previous malaria vaccinations or infections, BMI 18 to 30, recruited sequentially, assigned to these dose cohorts and randomly assigned to receive the monoclonal antibody at 1.5, 5, 10, or 40 milligrams per kilogram intravenously, or 5 milligrams per kilogram subcutaneously, or placebo, with dose escalation staggered by 2 weeks interval. So the placebo is actually an identical buffer solution, right, which makes sense versus a saline. An untreated infectivity control was enrolled to support evaluation of protected efficacy. Participants from the MAM-01 and control groups underwent, you ready for this, controlled human malaria infection via the bites of 5 mosquitoes. What fun. The mosquitoes were infected with P. falciparum, NF54, strain 18-20, 6 weeks after monoclonal antibody, right? So they get the monoclonal antibodies, and then 18 to 26 weeks after they get bitten by the mosquitoes. After malaria, challenge participants were followed up daily by ultrasensitive PCR-based malaria detection on days 6 through 17, with continued follow-up of participants remaining aparasitemic on days 20, 23, 27. Participants who tested positive were treated. The primary outcome was safety and tolerability of MAM-01 at each dose level and after MAM-01 dosing. Right. So remember, the primary outcome here is really supposed to be safety, tolerability. We're trying to get some pharmacokinetic properties. That's the secondary outcomes, pharmacokinetic properties, and protective efficacy. Like, while we've got the data, safety was assessed in all the participants between August 14th, 2023, December 13, 2024. 63 participants were assessed for eligibility, 38 enrolled, 37 randomly assigned. After review of Sentinel group safety data, and that was just 1.5 milligram per kilogram. One person got that, placebo, one person got that. Then 29 participants were assigned to receive those various escalated doses. We ended up with 6 folks in the placebo group. Now, one participant was included as an untreated infectivity control. MAM-01 administration well tolerated, no treatment-related serious adverse events occurred. After controlled human malaria infection, 6 of 6 participants in the control group and 18 of 22 participants in the MAM-01 group developed parasitemia. None of the 3 participants in the highest dose, that's the 40 milligram per kilogram intravenous dose group, developed parasitemia. The pharmacokinetic analysis showed that serum MAM-01 concentrations greater than 88 microgram per ml protected against malaria challenge. So sort of exciting, but very preliminary at this point. All right, now this is a very fun one, Sara.
You swooped in. I pinned this one, and you had already put it in, so I let you keep it. But I really wanted to add it.
Should I let you go through it?
No. Go ahead.
Are you sure? Because we do a deep.
It's really cool.
We do a deep dive on this one on our This Week in Parasitism. So this is going to get like double dipped. But so this is the article, and please jump in, Sara, because it's a great one. Permethrin-treated baby wraps for the prevention of malaria, published in the England Journal of Medicine. So here's double-blind, randomized placebo-controlled trial conducted in Uganda. And here's what they're basically going to do. So in Uganda, in many parts of the world, the children are carried in these wraps. You've got like a large bit of cloth, and then basically the baby's in the cloth, and then you tie it around, and then the baby is carried around this way. So these, and I must admit, this is how I carried my kids around. I don't know, Sara, but maybe I'm a hippie or something, but it's super handy, right? Because I could like throw the kid in there, tie it around. I could play my flute. I could cut the grass, and the kids don't mind. They love just moving around. They could be upside down. You throw them behind you for certain things, bring them to the front. But so they take these wraps and then they're going to soak them in this either basically placebo, like sham soak, or they're going to soak them in the permethrin. I do this to my clothes sometimes before I go to like Panama and Africa. And so this permethrin, right, is a chrysanthemum-based insecticide. And so they're gonna do this, like, half the folks are gonna get treated, half the folks are gonna get untreated. And then once a month, they're gonna retreat the rats. We don't know if they need to do them quite that often. And everyone also, this is a background of everyone also getting insecticide-treated bed nets. They're gonna come to the clinic every 2 weeks for 24 weeks. The primary outcome was clinical malaria in the children as defined by fever and a positive malaria rapid diagnostic test. A total of 419 mother-child pairs were screened. 400 undergo randomization, so the data is very clean, right? 200 get intervened, 200 are in control. Clinical attendance is great. Like basically everyone comes and participates and they don't really lose anyone. The incidence rate of clinical malaria was 0.73 cases per 100 in the intervention, 2.14 per 100 person weeks in the control group. So we're seeing an incidence rate ratio of 0.34, right? So that's like a 66% reduction. They're going to actually give us sort of a different number the way they calculate it, but really pretty impressive, like on top of this of sort of the background reduction. They've got some nice, I love the figure. They've got pictures of these just bright, beautiful, colorful wraps and all the different ways that you can carry the babies.
Yeah, I love it.
All right. Now, what's really interesting, I didn't include this here, but, sort of the following it over time, and you can really see this separation over time. So, all right, and I am going to finish us off our last article in the miscellaneous section. This is miscellaneous, but I found it interesting and worthy of discussion. The article, Ambient Documentation Technology in Clinician Experience of Documentation Burden and Burnout, published in JAMA Network Open. So we all know that all that documentation is associated with clinician burnout. Maybe not ID docs, right? We're always trying to write that, I get the Nobel Prize for this wonderful, 5-page H&P and discussion, assessment and plan here. But anyway, most normal people actually find the documentation to be a little bit over. And so here they use this technology called ambient documentation technology. So what you do is you turn on this artificial intelligence. It's listening to you while you're having these conversations, clinician-patient, and it's actually going to draft your clinical notes. We demoed this actually at our outpatient clinic. So the survey study included clinicians who used this ambient document technology, ADT, for at least 42 days. And then, this is a little bit tricky, they responded to both the pre and the post surveys. There may have been some selection bias on who actually responded. The main outcomes were the proportion of self-reported ADT usage, change in proportion of clinicians meeting the criteria for burnout or a positive outcome of their documentation practice associated with their well-being, and free text survey comments. So across MGB and Emory, so MGB, Mass General Brigham, and Emory, 1,430 clinicians, including 873 at MGB, 557 at Emory, are enrolled. The majority of the clinicians were physicians. Approximately equal proportions of clinicians practiced in primary care at the two sites. The response rate for relevant components of the MGB survey was 30%. For the 42-day mid-survey, 22% for the 84 post-day. For the Emory, the post-survey response was 11%. A total of 128 of the 264 MGB survey respondents, so about half, had self-reported using ADT for at least 50% of their patient visits, while about 43% self-reported usage at Emory. The proportion of the Mass General clinicians reporting burnout, they're using this Professional Fulfillment Index overall burnout score, decreased from 50% to 29.4% at 42 days, and in Emory, 52 down to 30%. So it seems to be going in the right direction. The proportion of Emory clinicians reporting a positive impact of their documentation practice on well-being improved from 1.6 to 32.3. This qualitative analysis of free text survey components revealed that physicians found improved joy in practice with ADT use. I love that. Now, what were the limitations, right? Because this is great, that this is just going to make, our practicing medicine more of a joy, less burnout. But they point out several limitations. So foremost, it was a non-controlled study, 2 academic medical centers with a limited number of vendors. So maybe not every ADT system is created the same. There was also a voluntary nature. So this may have sort of influenced who wants to participate in the ADT. So that may have also biased people that were maybe more excited about this concept, right? Academic clinicians may have a different clinical volume. I think, yes, academic clinicians do have quite a different patient volume from folks in private practice. They may also have different documentation patterns. They might be a little more excited and interested in the excellence and the thoroughness of their documentation versus those in private practice, maybe, or just really trying to be sort of terse and, needing what they do. Clinician experience, would really need to be compared with non-academic clinicians. And also with this response rate, it's also possible that their findings represent the experience of users with really strong opinions and might not really represent the overall experience. But they do conclude across the survey studies at 2 academic medical centers limited by low response rate and therefore possibly representing enthusiastic users, ADT was associated with significant reductions in burnout and improvements in perceived documentation-related well-being.
Love it. Well, this brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube, and then make sure to subscribe, like us, ring the bell, and leave comments. We'd love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. Now, if you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com. Click on that donate button. And I'm just going to sort of a shout out to all our listeners here. Often I run into sort of these people who've been in practice maybe for more years than I have, who kind of feel like they're sort of, riding on recommendations from decades ago. So for all of you that listen, I'm very excited to continue to be able to keep doing this. Very excited for all of you who want to hear the latest studies so that your recommendations are not just, experience-based, based on doing the same thing over and over with increasing levels of confidence and not necessarily increasing levels of scientific certainty. So keep helping us do this, and thank you for taking the time to listen.
I'm Sara Dong. You can find me on Blue Sky at Sarah Wynn Dong or at Febrile Podcast.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcast, This Week in Parasitism. Thanks for the comment before, and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.